All right, here we are, part 5.
Part 5.
Welcome back.
So exciting.
Let's
Let's
do it.
just jump right in. The 7 P's of RSI. This has been a long-standing mnemonic to help us remember the things we need to do for RSI. So we're just going to hit preparation first. Preparation, there's another mnemonic. It's an acronym. And we'll talk about that, but it's making a plan and having a backup plan. So, Josh, do you want to talk about Stop Made?
Yeah, so I mean, this is an acronym that I've read about in books, and it's good. Honestly, it should not replace the checklist.
Your checklist should have all of this.
I would say
as
use this to
an
make a checklist.
Integral part.
Yes. So, anyways, so you want to have your suction out and on and ready. And every time I intubate, I like the decantos. Is decano or decanter?
Decanter is it holds a drink.
Yeah,
Decanto is the doctor
I
that
like
made
the
the big.
decantos better than the Yonkers, but I'd get the decanto out and I stick it underneath the pillow or whatever the patient's resting on, right? So it's right there and suction's running. And it's always in the same place for me every time, so that when I need it, it's there. And
Suction running is a big deal because inevitably, and I've been in a few ambulances in my day, if you need to turn suction on in the more modern ambulances, it's on a screen and it's sometimes like a couple of screens. It's not like a switch like it used to be. It used to be just a light switch or a knob. Not anymore. Usually now you have a couple of steps. So just have it on.
yeah. And you'll be intubating in the back. You'll be doing this in the back of an ambulance. You may be doing this in someone's house. You may be doing this in the ER, right? So you may have portable suction, but whatever you do, have your suction out, have your suction on, and check it and make sure that it's all connected and actually has suction. Tools, get out the things that you're going to need to actually place this ET tube, right? So whether you're going to do DL or VL, make sure you have the right stylet. If you have a hyperangulated blade, you need the rigid stylet. Also, rescue tools as well. So, crite kit out, if that's a possibility, or if you're going to use an EG, an extraglottic device, if you need to, like, have that out. Have your ET tube out. Have it checked. Check the cuff, right? Everything ready to go. All of that stuff. And I always put it all in the same place. So
Yes,
I'll have an
me too.
OPA.
I want it all in the same place.
Yeah. So however you do it, just always lay it out. I put the OPA on their chest. So if I need to grab it to bag them back up, so it's muscle memory. I can reach for it if I need to bag them, pop it in to, oxygenate them back up.
And I would say, just because we taught an agency that was like, we only use video, we only need to learn about video. I love that. I love that you want to have video for every intubation. But I personally have had intubations where I had to switch from video to direct because of the massively soiled airway, even with a salad technique, because of the situation where I can't see the screen properly. So I don't think that you're putting yourself ahead if you don't have your direct tools out. You might have a policy that says use video for first attempt, which I 100% agree with, but don't cut yourself short by not having those other tools out because you might need to switch. And I know some videos you can immediately just switch and start to look.
You mean certain scopes?
Certain scopes, yes. But
they have a different blade. Yeah. Okay. O for oxygen source. So if you're using portable oxygen, then make sure your tank is full. Make sure that your bag valve mask is attached and that it's running. You don't want to have to turn anything on or off. So you want the oxygen flow that you want already running. Also, if you're going to do the passive oxygenation, which we recommend, which you'll need to have a second oxygen source or at least a Y on your oxygen bottle. Put the cannula on the patient for the passive oxygenation, positioning the patient. So this is positioning them for placement of the ET tube, right, but also positioning them for maximum oxygenation. So whether you're going to ramp the patient, depending on neck flexibility and things like that, get them in the position that you want, but also if you're in the ER, right, get the bed up to the height that you want. Do you want the head of bed elevated while you're intubating? So get the patient positioned and ready. And for monitors, so you're going to want a SAP probe on with good pleth, right? So you know that you're accurately visualizing their oxygen saturation.
If their distal circulation is garbage, you need to have another way to monitor that.
Whether that's an earlobe one
Yes.
or a nasal,
However,
the one that hooks to their nose.
Yes.
And tidal CO2, obviously this is critical. So people have different varying opinions on this. There is a little dead space. I like to put the inline end tidal on between my bag and my mask.
I do too.
Okay, so that's how I do it. Some people, which I don't know if I agree with, say put the capno line, the cannula end tidal tubing on their nose and use that to monitor their end tidal CO2, but you can't use that once they're intubated. So.
And it does not pre-oxygenate the way a regular cannula does. So you need to be aware that I like to put a cannula on for pre-ox, and we'll talk about that. But just know your end tidal cannula does not deliver oxygen through the prongs, so it's not as effective at pre-ox. And then
great. So yeah, have your end tidal out, have it attached to your monitor. If you use the Zoll monitors, you have to actually push the CO2 button to get it to bring up waveforms, right? So have all of that out ready to go. EKG, so that your heart rate is based on the EKG, not just the finger probe.
And it does help you get a better reading for your blood pressures as well when you're using the oscillometric devices, which is what we all use.
Yeah. EID, so if you use those, esophageal intubation detector. So what the tools that you're going to use to confirm placement, right, of this. A stethoscope, which is not the primary way to secure or to ensure that the tube is in the right place, but it will help you determine if you're right main stemmed, which is common to go a little bit too far with the ET tube. But we rely on end tidal CO2 waveform to confirm that we're actually in the trachea. Blood pressure cuff on, ready to go.
And set at a cycle so that you're not having to keep pushing the button. I think it's absolutely appropriate to just set it at a 3 to 5 minute interval so that I know I'm constantly getting repeat pressures.
Yeah. I would 3 for me would be that's the most I would allow it to go without taking another blood pressure. So I'd set it to go every 3 or even less personally, but
I think that most monitors, it's hard, and hospital might be a little different, but the ones in the field, because of their limitation and the way that they read, I think the lowest they do have it's called the turbo cuff, where it's just like,
yeah.
And I've had less luck with that, but because it does have to allow full filling before it can read another good pressure. So
know your equipment, know how to use it. Assistant, right? So this is going to be who's helping you, right? Someone's handing you the tube. That may be the person that may be providing external laryngeal manipulation pressure. You want one person's job is to push the meds. That's not going to be you at the head if you're the one intubating. And I would just say, we'll save that for later. Anyways, also somebody to watch the monitor and give you live reportings of saturations 100, saturations 99, heart rates up. So they're just, so you don't have to look at the monitor, someone's there reading it, right?
IV access.
Well, before that.
Oh, are you still?
We already hit all those.
Mm-hmm. So.
Okay. At this point could also be airway assessment, which, we've gone through that, the lemon assessing. Okay, what are we working with here? And then obviously there's A there for airway devices, which I put in under tools, but put it where you want. IV access. So not just IV access, but preferably in this situation, this is a sick patient. So 2 IV lines in case one fails.
Yes, that I can't get over how many times people will just get one point of access with their super sick patients. And I know that you can push things together, but if you have a presser running, whether it's on a pump or a gravity feed, and then you need to push a med and you've got to flush that line, push your med, flush the line, start your presser. If that patient really needs a presser, you shouldn't be stopping it. Like you need to have 2 points of access.
Yeah. And now also you need to have a bag of fluid hanging and running. It needs to be running, not, and this may be a patient who's you want to restrict fluids because they're already overloaded, but you've got to have it open and dripping so that when I push these meds, they're going to drip right in. And then, if they are on fluid restriction, and this may just be for the intubation process, and then you can, turn it off and take it off.
You're not dumping 500 into them or 1,000 into them.
This is just the pathway for your drugs to go right into the patient. Okay, and then that takes us to D, drugs. So you want not only if you are gonna pre-medicate them with fentanyl, that's where you get that out. Induction agents, and this is part of your plan. Is like, what agents are we going to use? What doses are we going to use? Have everything drawn up and labeled, because you may have a number of syringes sitting there for different points during the process. Also, don't forget post-intubation sedation ready to go. So whether you're going to be putting them on like a continuous propofol drip, or whether you're going to be doing push dose sedation, which is pretty common, where we'll use, where I work, fentanyl and Versed. And so I'll have those ready.
Just have a plan.
Right, because your induction agent, if you're using something like etomidate, it's going to wear off fast. And if you're using a long-acting...
Like rock.
Yeah, like rock, then the sedation or your induction agent wears off, and now they're conscious but paralyzed, and you don't want that, right? So you got to have, what are we going to use, a plan, and then those drugs ready to go. So have Versed and fentanyl syringe ready to go to start inducing sedation once you get this airway taking. Also, and we hope this doesn't happen, and we're going to talk about, pre-intubation optimization, getting their vital signs up and ready to receive what you're about to do to them and give to them. But, have your push dose pressors out, and if you think there's a chance that you're going to use that, if you carry phenylephrine, that's one that they like to use in the OR. It's purely alpha agonist. It doesn't have any beta effects. And so anesthesiologists love this one when the patient becomes hypotensive because of the medications that they've pushed, not because of a physiological, not because they're in shock or whatever. And so they'll use that to reverse the effects of the drugs that they've pushed.
Yeah. Okay. Now, in this slide, preparation, we're not going to sit and go over these again. It's just to know that those acronyms that we taught you are there to help you prepare. You need a plan for oxygenation and then a plan for your approach to the airway. So that's what those are for. I don't think we need to hash this out again. So let's talk about our airway algorithms. Okay, the emergency airway algorithm is there once you've decided the patient needs intubation. Then you're asking, are they in full arrest? Are they agonally breathing? If that's yes, then you are to jump over to the cardiac arrest airway tree or algorithm. If it's no, then you ask, is it a predicted difficult airway? If yes, you go to the difficult airway, which is on this slide as well. If no, you move to RSI. So you can see, and then it has a repeat of an intubation attempt. Was it successful? Was it not? Failure, and it moves down in a systematic way. And some of these people might think are intuitive, but there is a reason these are created, and it's not just for pre-hospital providers. These are created for physicians and anesthesiologists. So it would be to our benefit to be aware of them and use them. In the difficult airway algorithm, you can see there's a few more options, but this is where there is a predicted difficult airway. This is where pre-hospital providers are different than clinical providers, because the first thing they do if it's predicted to be difficult, is they call for assistance. We don't always have that option. Sometimes you're the guy or the girl. You're the one.
Yeah, you're not calling the OR. Hey, can we have one of your anesthesiologists come down, please?
Can I get a flexible endoscope in here we don't have that. So just know that if you need help, get your team assembled. If you think it's going to be bad, get everything that you can to help you. Are you forced to act? That's the next question. If it's like, we've got to do this now because the patient's going to die, you're going to go to give your RSI drugs and give one best attempt. Okay, one best attempt is like not the new person that's practicing their intubation.
Not your orienting paramedic.
No. You got to have someone who's the guy that you would count on to do it. And even those people have their days when they don't hit it. And so, but you want best attempt, right? As you go down, if that's successful, of course, it's post-intubation management. But if not, you're going to the failed airway algorithm. Now, you can look at these. I want you guys to take time to kind of study these algorithms. Questions on the test for critical care do refer to these. Not directly, they don't say in the airway algorithm, but they ask questions posing as if this happens and this happens. What's the next?
And your next
step?
The answer is the next step in the algorithm.
Yes,
if you don't know the algorithm.
Because these are universal in not just in the United States, but these are considered a standard of care. So know these. I don't feel like we need to go through every step because you guys can do that. So the crash airway is the cardiac arrest scenario when you're not really pushing drugs. This is not an RSI. This needs to happen right now. The patient does not need to be sedated because they're dying or dead.
Or mostly dead.
It's just BVM or extraglottic. If the ventilation with an EGD is successful, then ask yourself, do we need to intubate? We might not need to. If it is not successful, if you're unable to get good seal or good ventilatory chest rise, you're going to move to a definitive airway in some way. Now, did you get ROSC? No ROSC? Then you go back up to ventilation. It just takes you in a circle. But if you did get ROSC, then go into the difficult airway management. These are all overlapping. The last one we're going to cover is a failed airway. If it's a failed airway, you definitely want assistance. But again, we don't always have that. Ask yourself, is there a failure to maintain oxygenation? And if it is yes, meaning they cannot oxygenate, you are looking at a potential cric at that point. And remember that the criteria for cric is can't intubate, can't oxygenate. And so this is where that decision is made. If they are oxygenating, then you move to, do you have another tool that will help you get the tube? Do you have a better video scope? Do you have a hyperangulated blade?
A bougie.
Yeah, like what can you do to make this more successful on this next attempt? And then from
positioning the patient.
And then if you did place the ET tube, you just manage them post-intubation. If not, you've got to get that airway managed. You got to get a definitive airway. And it's either cric or you're successful at this point. Like there's no more decision making. Now let's talk about pre-oxygenation. We have a few slides about this, and it is the ramping we've mentioned many times. It's all part of the positioning, but this makes a huge difference in our attempt and in our pre-oxygenation. The nitrogen washout that we're attempting to have in the lungs, and I think we've hit this enough, but I still have providers in the field that want to bring up oxygen is toxic, Rebecca.
Yeah.
There's the oxygen toxicity. And I understand that. I agree.
This is not for long term. This is for a procedure.
A few minutes. This is like going to be just enough to give them a gradient where they're going to oxygenate even if we're not ventilating.
Yeah. So I had one of our medical control anesthesiologist physicians really help me appreciate this. And I'd like to share that. So just look at your lungs as if you've got 2 1-liter containers, right? And right now, they're full of 2 liters of gas. 78% of that 2 liters is nitrogen, and 21% of that 2 liters is oxygen. Now, the average person, adult, will think of gas as a liquid or a fluid, right? We measure it in volumes. And so the average person uses 250 milliliters a minute of oxygen. All right. So if you take that 78% nitrogen and 21% oxygen, through pre-oxygenating them, turn it into 2 liters of 100% oxygen. That's all that's in there. That's 2,000 milliliters of oxygen. 250 milliliters a minute going into 2,000 milliliters of available oxygen. That goes into it 8 times. So they have 8 minutes worth of oxygen.
I love that analogy.
By filling up these containers with oxygen.
I love that analogy. Even just this week, I was met with the argument of, well, the nitrogen, if you understand physiology, it stimulates the goblet cells that produce surfactant. And I am not arguing that. I get it. Yes, it does. But this is a very quick procedure that we are setting ourselves up so this patient doesn't desaturate. So please know that we're not going to leave them at this for the next hour or, overnight. They get this for a few minutes. And it doesn't take that long. It shouldn't be taking us that long. But just know that argument can be laid to rest. All right. So we are going to give them a lot of oxygen. If you note on the slide, you need to pre-oxygenate for 3 minutes at least, or at the very least 8 vital capacity breaths.
Of 100% oxygen.
Of 100% oxygen. And so vital capacity is not just your normal like in and out breath, right? It's breathing in at a tidal volume and then in as much as you can take in. That's your vital capacity.
Watching your pressure, because if you're assisting these with ventilation, if they're not spontaneously breathing,
yes.
You don't want to pop their lungs. We're also looking at pressures, right?
But yes, because we don't want to put it in their stomach either.
Right.
That's just going to make things. I told you earlier, I heard the best term. It's called gentilation instead of ventilation, because you're doing it gently, but you're providing a vital capacity breath.
So say you are assisting the ventilations as they're doing this, right? And you give them 7 good breaths of 100% oxygen with a good mask seal, right?
Mm-hmm.
And then you pull away and they take a big, deep gas of atmospheric air. They're back to 21% oxygen, 78% nitrogen. You have to keep them at 100% filled with oxygen.
And there's a whole discussion there because when someone is spontaneously breathing and you're assisting them, be aware of your tools and your BVM and how that works. Anyway, you can put the NRB at a high flow. You can flush rate your nasal cannula and then add a non-rebreather on top of that.
And if you look on your flow meters that attach to your ambulance wall or the wall in the hospital, it will tell you. So when you turn it up to max, right, and the little ball floats up all the way to the top, on the side, on the metal part of those meters, it will tell you how many liters they're getting at max flow.
At max flow.
And I believe it has to be a max, for this to be effective, it has to be a max flow. I think the book said 40 liters per minute.
So that's a lot. Not all flow meters will, I don't know. You check your flow meters is what we're saying.
Yeah, because they don't all flow at max. They don't all flow that many liters. So,
which is why you would want one oxygen source on a cannula at flush rate and a mask at a flush rate.
right. But if you're just doing the mask, which is one of the most effective ways to pre-oxygenate a spontaneously breathing patient,
Yes.
throw the mask on and crank it up to high flow, and they need to breathe that for 3 minutes.
Yeah. Inadequate spontaneously breathing patients. This is where we're getting into very gentle bag ventilation. The inspiratory pressure you want, the peak inspiratory pressure is 20 or less. And this says millimeters of mercury. Just so.
All right, fix that, Josh. Pause.
All right. You can use that BVM at 15 liters per minute. I don't know what the research says. If you turn it up higher than that, the delivery through the mask on a BVM, it depends. So just know your equipment. Passive oxygenation, this is where we're talking about a flush rate nasal cannula at 15 liters per minute. And yes, if you left the patient on this flush rate cannula for a long time, they would get a nosebleed. It would hurt. This is temporary, short-term pre-oxygenation. And then positioning. If your patient is supine and flat, they're not oxygenating as well as they would be as if you ramped them or set them up and helped optimize all of the pressures in their lungs and everything with their position of their head. So note that 20-degree head up or 30-degree reverse Trendelenburg, and that just means if they're flat, you're just making their whole body at a 30-degree angle.
You'll note. Oh, you were going to talk about ramping. Go ahead.
No, you go for it.
So, I mean, if you'll notice on this obese patient here, the ramping is essentially you literally build a ramp behind them with pillows and blankets, right? So you've got this angle up their back, and then it flattens off where their head goes. And that's for these obese patients where their giant body habitus puts their head in a position that is less than desirable for intubating.
Yeah.
And so ramping obese patients or patients with like neck mobility issues can really optimize your ability to view the glottic opening, or as I like to call it, the air hole.
The air hole. And then make sure you're optimizing ear to sternal notch line, and think of your axes that we talked about earlier. Are you aligning those to be optimized? And then use some adjuncts if you can. That's always preferred. This is just a quick review of our time to desaturation, the patients we need to be aware of. How much time do we have? Are they properly pre-oxygenated? Because if the highest I can get my patient to is 94% with all of my efforts at pre-oxygenation, I should just be aware that I have less time with this patient. So that's something we can't drive home enough, is that you need a plan for oxygenating your patient, and you need to be aware of how long they're going to stay oxygenated. Now, the next P is pre-intubation optimization. So we've already talked about poor physiological status.
This goes back to the crash algorithm.
Yes.
Arguably the most important P in the 7 Ps here.
Yes. We have the ability, even in the field, to optimize the patient's physiological status. All of us have fluids. We all have some pressor available to us, analgesics. Not everyone has blood. I do feel like we are going to see that on most ground agencies in the near future. But this is our job as clinicians, to recognize we need to account for this and have it not just sitting on the action area or on the counter, but like have it ready, have it on. So that's important. Paralysis with induction. This is the rapid portion of the RSI. You rapidly push the full dose of the induction agent.
I don't like to make this fit along with the P's, paralysis with induction. The induction agent goes first.
Yeah,
the paralytic goes immediately second. Both are pushed fast.
So just know we're not delaying. There is delayed sequence intubation. Thanks, Scott Weingart. He's, great. But right now we're talking about RSI. So induction and then your paralytic, whatever that is. And then 45 to 60 seconds to make sure that it's all working. And then you're going to go for it. Let's talk specifically about some of our induction agents. Etomidate is probably the most common that we hear. It's what my agency uses. The standard dose is 0.03 milligrams per kilogram, IV or IO. It takes 15 to 45 seconds to work. The duration is 3 to 12 minutes. That's why we have to have a plan for post-intubation sedation. We cannot just let this ride, because we do not want our patients paralyzed and aware. So they need to be sedated. It's the most hemodynamically stable of all the induction agents. And they've actually recently shown that it's even more so than they used to think, because they used to have some restrictions with it, but it's pretty safe. The cons, it could cause myoclonus, a mild increase.
Which I never got that, because you're about to paralyze them.
I know.
That myoclonus is going to disappear.
It's not going to happen, right? You're going to take that away. Mild increase in airway resistance.
But I guess while you're waiting for the paralytic to work, if now they lock their jaw up and you're not able to oxygenate them,
that would
if
be
it's one of those ones who won't tolerate apnea. But anyways.
So an increase in airway resistance, just be aware of this. If you have a patient who already has a lot of airway resistance, this might be a tipping point. And then adrenocortical suppression, and they've kind of debunked this concern as far as in an emergency setting, but be aware that it does have some adrenal suppression.
The thought is with like a septic patient, right? And all their stress hormones are keeping them alive. And then this reduces some of their stress hormones, so their ability to continue to fight goes down, but we just give them steroids.
Yeah, we have ways to manage that as their care goes forward.
Yeah, so realistically, in all the years I've been giving etomidate, this has never come up as an issue. Put it on there more for testing purposes than anything, because if it's the appropriate drug, it's the appropriate drug.
Yes. And remember, there is no analgesia with etomidate, so you need to
just unconsciousness.
Yeah, you need to give them something, because this is a painful procedure. All right, let's move on to propofol. This I see more as a maintenance sedation than an induction, but sometimes it is in the OR. So
yeah, they'll use it specifically in the OR for RSI quite frequently. And then in the field, if you're on a longer transport, it's nice to just keep a nice steady sedation going on the patient. But frequently I would just go to push dose sedation. But it is there, and it is nice, because if you get busy, you got a patient who's trying to die on you, and then you miss a dose, and
it's a trouble.
Then they start fighting the vent, right? So sometimes it's nice to just throw the propofol on.
So this is what my agency uses as maintenance, and we do have IV pumps, so we can set it on the pump, and it's quickly, it's very easy to turn up or turn down, adjust as we see fit. Just know that the induction dose is usually 1.5 to 3 milligrams per kilogram in an IV, and then it takes 15 to 45 seconds as well to have full effect. The duration is 5 to 10 minutes. This is why everyone loves propofol, because it's quick on and very quick off. It reduces airway resistance. It has anticonvulsant effects, but it can decrease their MAP pretty significantly.
It will decrease their MAP. So if they're already,
this says usually by 10 millimeters of mercury, it can be worse than that.
Yeah. So plan on, it's going to drop their pressure. So anyone who can't tolerate that, this is not the drug to go with. However, specifically, you talked about the airway resistance. It's good for asthma patients, but it also, so is ketamine.
Yeah. So just be aware of it. It also has no analgesia. So you're going to need to give them some management of their pain with propofol. Now let's get on to vitamin K. The induction dose is 1 to 2 milligrams per kilogram IV. It takes, again, 45 to 60 seconds to come on to full effect. And it usually lasts 10 to 20 minutes from the time that you pushed it. Ketamine has long been thought to keep patients hemodynamically stable. But if you look at the research that's been done, is that it counts on you having a supply of catecholamines. And if you're giving this in a patient who is catecholamine deplete due to their condition, you will not have that little safety net that we think ketamine comes with. In fact, it was shown to act as a negative inotrope at that point. When you don't have the catecholamines to support things, ketamine can
make it worse.
Yeah. So it's not the save all, superhero.
It doesn't replace the pre-intubation optimization. Oh, their blood pressure's low, we'll just use ketamine.
Yes. Be aware of that.
And I just want you to note that induction dose. That is not a pain dose. That's a make you unconscious dose.
Yeah. Not a pain dose.
A pain dose is 0.3 milligrams per kilogram. So this is quite a bit more.
As we look a little more into it, it does have a lot of pros. It preserves their respiratory drive if you push it slowly. And it stimulates their catecholamine receptors, like I mentioned. But if they're out of catecholamines, you do have a limited supply because your body's constantly producing them, then you won't get that support. It can increase their heart rate, contractility, and MAP if they have catecholamines. It is been shown to increase bronchodilation, and it does have analgesia, which is very positive.
That's one of the great things about this. It both does induce, but it does it in a way that also manages their pain, whereas most of these other ones do not. Etomidate, propofol, Versed.
Yeah. So the cons they list here, it increases their oxygen consumption depending on your patient. So if you already have a patient who has a high consumption due to their pathology, consider that, because ketamine can bump that a little bit, which we don't want. And then there is that reemergent phenomenon where they kind of get a little out of it.
You mean Rodney King? They become Rodney King. Fight and fight and fight.
Yeah, I've actually experienced patients with this phenomenon, and it is bananas. They are not present mentally.
The option to help reduce that is give them a little bit of Versed with it.
Versed will help calm that down. It doesn't work as good, after they're in full tilt crazy, but if you can pre-treat them a little or get it ready, I think that's helpful.
I've also heard the environment they go in under will add to how they respond as they're emerging, and so put on a little Kenny G, dim the lights.
I haven't actually thought about that, but I did hear through multiple sources that if they are sedated with happy thoughts, they tend to stay in a happy place while they're coming out. That's what I've been told. So I will talk a patient through
their happy place.
Yes, I will try to make things very nice for them.
Pictures of beer, beautiful women riding around. Oh no, it wasn't the woman on the trike. The little small person riding around on the trike. Butterflies floating around.
Yeah, whatever it takes to help them, that would be probably advised. Now, let's talk about Versed. This is a less known induction agent. We all carry it.
It's not a good induction agent.
It's not a good induction agent.
It's like, oh, crap.
I got nothing else.
We accidentally left our other agents back in the base.
Yeah. So the induction dose is 0.1 to 0.3 milligrams per kilogram. The 0.2 is a routine dose. The time to effect is very similar, 30 to 60 seconds. the duration of action can be much longer, 15 to 30 minutes. And it's, as I understand, because I've never used this for this purpose, but it can be variable. Like you're not sure if they're in or out, and it's hard to tell. It does have anticonvulsant effects. It can significantly drop their MAP and cause some hypotension, and it takes high doses, so it's frequently underdosed.
So ultimately, the two agents that we'll see used out in the field is ketamine or etomidate for induction agents. Yes.
But be aware of all of these for the test. Also know Versed does not have analgesia. It does cause some memory.
It has amnesia.
Yeah, it can make you not remember, but that doesn't mean that we shouldn't treat their pain as well. But a combination of these two, like a fentanyl Versed combo, you can take away their breathing really pretty quickly. So be aware.
They're great for continued sedation for sure as a combo. Okay, we're going to go ahead and cut there, and we'll pick up in part 6, starting with paralytics. Thanks, Rebecca.